Thank you, everyone, for coming. It's my great pleasure to introduce you today to our distinguished speaker for our Sudanese Infectious Disease Association Grand Round today, Dr. Wael Al-Amin. Dr. Wael Al-Amin is a consultant clinical microbiologist and infection control specialist with extensive experience across both the United Kingdom and the United Arab Emirates. He brings with him a remarkable academic and professional background, having earned degrees from Sudan, the UK, and Germany, and holding prestigious fellowships from the Royal College of Pathologists and the Royal College of Physicians. Over the years, Dr. Al-Amin has led numerous impactful projects in antimicrobial stewardship, pathology services, and outbreak investigations. His work has been recognized nationally and internationally, earning him multiple awards. A prolific researcher, he has published widely on critical topics including Helicobacter pylori, multidrug resistant organisms, and antimicrobial resistance in conflict settings. He also contributes to academia as an adjunct professor at Khalifa University in Abu Dhabi, and as a senior lecturer at Queen Mary University of London. Currently, Dr. Al-Amin serves as the medical director and subject matter expert in microbiology and infectious diseases at G42 Healthcare, where he is at the forefront of cutting-edge projects leveraging data and artificial intelligence to drive innovation in healthcare. Please join me in welcoming Dr. Wael Al-Amin.
Assalamu alaikum. Thank you very much, Azadeen, for the kind introduction. And I think sometimes it's very difficult to speak to experts about a topic that they would probably know a lot more about than oneself. We initially had a few discussions about what should we talk about that may be of interest to all, and it came, the choice of Candida auris came about following discussions of patients in the group that we all share, and the difficulty in managing Candida auris. And it happens to be that our team has been working recently in Candida auris from environmental samples. So we'll try and make this as flowing in a way that we have a discussion later. So we'll go through the introductions, and then the introduction will include some regional epidemiology and what's happening with Candida auris within the region here. I'll start talking about wastewater surveillance, which is a topic that many clinicians would not know much about. And then we'll see a little bit of our findings. I'll discuss a little bit of our findings from what we have found within the current work that we're doing. So Candida, the etymology comes from the Latin word candidus, and that is white. And by white, it's been described whenever you grow it on a plate, you'd know all of that. Candida classically is white on the plate. And the auris bit is attributed to where this yeast was first identified. First was identified in around 2009 from a patient in Japan. A yeast was identified from their ear, although there's documented evidence that it's been in Korea since 1996. And in around 2012, actually, I recall myself, I was working, we had Maldito first installed in our laboratory in England. And I remember encountering this about 2 to 3 years before the outbreak, and we did a retrospective analysis at the time when we realized that we've missed quite a few patients, thinking that it would be just another commensal yeast out of ignorance at the time. It came into prominence in around 2014-15 with a global outbreak, started in the UK, in an ICU in the UK with significant mortality and morbidity. And what people found at the time was the difficulty in getting rid of it. Apart from the unusual resistance patterns, the interest was actually how it persisted in the environment in ICUs. As we all know, it went on to become a target organism with significant mortality and morbidity associated with immune-compromised patients. And it rarely affects healthy individuals. However, one of the difficulties is there's a lot of colonization that happens. So the mortality documented for clinical cases ranges between 20 to 70%, depending on the setting. And The antimicrobial reported resistance, and this is very important because we don't have breakpoints for Candida auris, has been reported as resistant to at least 90% of the isolates have been reported as resistant to at least one antifungal agent, with up to 30% of isolates resistant to at least two antifungal agents. And some people may argue that these numbers are actually inaccurate in the fact that a lot of the times, a lot of the clinical expertise would come and say, actually, the patient is not responding. So when we talk about resistance, as I mentioned earlier, the lack of breakpoints makes it very difficult to interpret this epidemiology. One other problem is we have a lot of asymptomatic carriers. So there's a lot of asymptomatic carriage of Candida auris, and there isn't any known other carrier apart from humans so far. Although it has been reported as identified in pets as a zoonotic pathogen in certain pets, including cats and dogs. But the primary host so far is believed to be humans. And one other issue is, as I mentioned earlier on, there's been a significant misidentification, and until the introduction of Molditov, a lot of these yeasts have been disqualified and discredited. And a lot of patients would have been mismanaged. So like any other organism, and like we'd have in a lot of bacteriology, there's a lot of different Candida auris, and that with a lot of geographical distinct clades. And the importance of this is it's quite significant when you talk about the clades and their relativity. So we all know that in bacteriology, you'd have a lot of different clades. For example, Klebsiellas, you'd find a lot of them with particular resistance associated with different geographical clades. The most famous of them, the nomenclature was associated. You'd have the New Delhi metallo-beta lactamases, you'd have the KPCs in North America for resistance. The same is applicable to these Candidae. There's 6 known clades until recently, until 2024. There were only 5 reported clades, but the 6th was reported from Indonesia in February of last year. The most prominent clade is the South Asian clade, predominantly in areas of South Asia, and it's the most distributed clade. The second common encountered is clade 2. Africa, like everything else, has a big gap, but there has been clade 3 reported, predominantly from South Africa. And then we have a South American clade reported from Colombia and Venezuela mostly. And in 2019, 2020, there was a clade 5, which is the Iranian clade, reported predominantly only from Iran at the time. So the clades have different characteristics. So you have clade 2 usually clade 2 is from East Asia, is usually fully susceptible, while clade 1 is partially, and clade 4 is usually resistant. Clade 6 exactly the same. Sorry, clade 5 and 6. So when we look at the clade distribution within the region, you'd find that in Saudi Arabia, the reports mostly are consistent with clade 1. And there has been some studies from King Fahad, I think, specialty hospital in Riyadh, of an outbreak and nosocomial transmission in 2018 to 2020 ongoing. And most of the sequencing consistently showed clade 1. Despite the overall assignment to clade 1, the detailed genomic investigations revealed a significant diversity. So there not only was it clade 1, but there was diversity within the clade. They examined 23 isolates from 20 patients, and they've found 4 distinct clusters and sublineages from clade 1 circulating. There was an independent study analyzing 8 of these isolates from 7 patients, and within these 8, they were able to break them to 2 subclades. And there was a lot of interesting dynamic within transmission with these sublineages and how they were transmitted within the hospital and the outbreak. So a lot of, again, there was multiple introductions, but then there was internal, which is very important. There was within the nosocomial transmission, there was evolution of these organisms within that particular hospital. I've kept the paper here for later on. Now, the resistance was, most of these were consistent with clade 1, as I mentioned, and a lot of them were reported as resistant to azoles, with several having the ERG11 mutation, which is consistent with amphotericin B and 5-fluocytosine resistance. Iran is an interesting case whereby in 2018 they've identified from a 14-year-old girl. They identified a single isolate at the time, and she had no travel history outside of Iran. They performed whole genome sequencing, and it was identified as a new clade, and it was divergent, significantly divergent, with more than 200,000 SMPs from clade 1. And following the analysis, they started looking at other isolates from other cities. So the first one, I think, was from Babel, and then the others were from Isfahan and Shiraz. And they continued looking at them, and they've identified multiple isolates from this new clade 5. Now, clade 5, the genetic distance is quite distant from clade 1, and it has been reported as being multi-drug resistant classically. So the important thing here is the phenotypic variability here is most of them were multi-drug resistant to both azoles and amphotericin. And it had an additional mutation, apart from the ERG11, which was a TAC1B mutation. So that was the one from the region here, from Iran. Then Kuwait, as you'd expect, because of the high migrant population from South Asia, mostly are clade 1. They had reported high fluconazole resistance, which you'd expect with clade 1, but again, there was a lot of variable amphotericin B resistance. And in the epidemiology, in that particular hospital in the outbreak, is they were able to demonstrate evolution of resistance to echinocandin. So there was de novo emergence during treatment in Kuwait. So it was within an individual patient. They had serial isolates which moved from low MIC to echinocandins to high MIC. So within the patient, the isolate or managed to evolve resistance, and that was secondary to a mutation in the FKS1 gene. So it was a substitution mutation. Oman, again, was a clade 1 with a nosocomial outbreak between 2018 to 2019, predominantly affecting ICU patients in Sohar Hospital. And the total number of patients was about 32. The isolates were from sterile samples, including blood cultures, and non-sterile samples, such as skin with colonization. Now, there was, all of these strains, though, had minimal variation. So there was no, unlike the strains in Saudi Arabia and in Kuwait, there was less variation in the clones. So this was a clonal outbreak, only single clone of clade 1 within the hospital in Oman. So as you can see, there isn't any consistency in what seems to be happening with these isolates. Qatar, again, was along with the COVID outbreak, COVID pandemic, there was a hospital outbreak. And I think they had about 19 patients in that outbreak. Most of it was fluconazole resistant. But unlike the others, the amphotericin resistant here was reported as much higher. So 70 to 85% of the isolates in Qatar were reported as amphotericin B resistant. The isolates were highly clonal, again, with one or likely only one introduction of a strain within that outbreak. The mutations associated, again, the ERG11 mutation was identified, and there was an FKS1 as well for echinocandins also in these isolates reported. So, and I think they reported a premature stop codon for ERG3 here. So there was the ERG1 and ERG3 identified within the isolates in Qatar. In Africa, there isn't much work, but there's a recent review, 2025. But unfortunately, as always, there's significant bias whereby most of the isolates, about 91% of the isolates, were from South Africa. So there's significant bias, and hence the clade that has been identified here is clade 3. So unfortunately, there's skew towards clade 3 from Africa. And the 90% plus was resistant to fluconazole, and about 20% to amphotericin B. Sudan, there was a paper from Sudan in 2018, 19, I think 2019. But unfortunately, the methodology one would describe as a little bit lacking, because what they did, it seems they've taken blood culture sample, or they've taken blood samples. They don't describe what type of sample, from 100 febrile patients, and they used polymerase chain reaction. But the epidemiology shows an incidence of about 26%, which I think is probably doubtful. They were using short primers specific for Candida auris. And I'd love, I mean, again, it's just improbable, but not impossible, knowing how the situation of infection control in Sudan was. But again, the methodology is not standard methodology for Candida auris or any yeast. As a matter of fact, as you all know, using PCR or molecular methods for yeast directly from blood culture is not neither sensitive nor specific. However, this is the only paper that we have from Sudan. So, what we did here was slightly different in the UAE. There was a case reported in 2018 from the UAE, from one of the first reported in the Middle East, and that isolate was sequenced and reported and banked. But we decided last year to start looking at wastewater surveillance as a means of monitoring risks and outbreaks for nearly almost everything. So we look for COVID, we look for influenza, we look for quite a few other pathogens. So over the last year, we decided to start looking also for Candida auris. The beauty of wastewater surveillance is you can monitor both symptomatic and asymptomatic carriage, because it doesn't matter. And it takes you away from a lot of the ethical approvals, because you don't have to go and identify their patients and patient identifiers and RBs. So for Candida, the method that we used, we actually took wastewater samples, literally more than 25,000 samples, and we managed to isolate it from 10, and the identification was done using MALDI-TOF. So we took samples from selected areas in Abu Dhabi and Al-Ain, close to and away from hospitals. We used culture methods. We developed our own method to dilute and concentrate together for the sample to try and identify it. And we did antifungal sensitivity testing based on MICs. And we did whole genome sequencing for all of the isolates that we've identified. So we managed to identify 10 samples. So from 23,000 samples, we were able to identify 10 samples, which gives us an incident rate of about 0.04%. So 4 in 1,000 roughly. We did the identification, confirmed it with Molotov, with highly probable species identification for all of the species that we've identified. And then we went over to try and create a reference genome. And to do that, we looked at the public available genomes with clade informations. So we took 2 from each clade. We took previously identified clade 1 from the UAE and 1 from India. We took 2 clade 2s, 1 from Japan, 1 from Canada. We took 2 clade 3s from the US and Canada, again available. So, and then the clade 4s from Colombia and Venezuela, clade 5 from Iran, and we took 3 clades from clade 6 from Singapore. If you recall, I said one of the biggest problems with Candida actually was the extraction of the DNA. The DNA extraction of Candida auris is not as easy as most people would imagine. We had to perform physical lysis, and then we used magnetic bead extraction, and then we used a MagMax Ultra kit, which magnetic bead based extraction. So we had to use 2 steps plus pre-lysis. And we sequenced the DNA using our MGI platform, which is short read sequencing. We did quality assessments to ensure that the yield is correct, and we had a very good yield for both of them, and a very good quality of yields. So then we did what we call Kamer-based classification, which assigned 22% of the yields of the breeds to Candida auris. And then we had to align it against a reference base to try and increase that to about 75%. The variation across the samples in terms of SMPs resulted in about more than 1,000 variants, with a lot of insertions and deletions that we had. So if you look at the indels here, so we have a lot of insertions and deletions, up to 1,000 roughly of insertions and deletions, and then there's a lot of other introns as well. So when we looked at the clade differentiation, we had one isolate that clustered, which is this one here. I don't know if you can see the mouse moving, or I'm sure. So so here there's a yellow box surrounding. There's a strain with AD23. Last 2 numbers are 38. So this is our strain, and it clustered with the Singaporean strains, which are clade 6, and then the remaining isolates, all of them clustered with clade 1. So we moved on to look at the distance between these clades. So we wanted to see how far away ours is from the other of the other clades from Singapore, and it was actually quite close to them. But what we've also identified that was not identified before is that clade 4 and clade 6 are also, so clade 4, which is colored in purple. I don't know, it's light purple. We have 2 purples here. And clade 6 are actually quite related. So the distance between clade 4 and 6 is actually quite similar. So the strains from Iran and the strains from Singapore seem to have, they cluster together. Then we went on to do some mating study. Okay, so I don't have the mating studies here. So we went over to do some mating analysis. And again, what we've identified is there seems to be some intraspecies mating between the clade predominantly 4 and 6, but not between the clade 1s. So the next thing that will come to anyone's mind is you'd want to see if there's any genetic basis for any antifungal resistance. So we created a pipeline looking at the known mutations for key resistance associations, which includes the ERG1, the FKS1, CYP51, beta tubulin, and TAC1B. And what we identified is on the only mutations that we found were actually on the clade 6 isolate, and predominantly there were 3 mutations associated with the ERG1, and all of them we're actually quite close to each other. So the cluster of these mutations very close to each other. So we did the antimicrobial sensitivity, and of course, as you know, there's no established breakpoints. So we used the CDC, the CLSI sort of tentative MIC breakpoints to report. So fluconazole more than 32, amphotericin B more than 2, and micafungin and indolfungin and caspofungin as above 2 and 4s. And of the 10 isolates, 2 of them were wild type, so they were susceptible to all of the tested antifungals that we had. The clade 6 isolate was resistant only to caspofungin, despite, so it's number 38. Where is it here? This one. Yeah, it was only was only resistant to caspofungin, strangely enough, despite the mutations which should infer an azole resistance, or at least we would have expected a slightly higher MIC for azoles. And then isolates without any genomic, we were not able to identify any genes associated with resistance, showed multi-drug resistance. So we had isolate number 15 here, 7515, was resistant to all the echinocandins despite it being wild type. And then we had isolate number 22, resistant to 3 different classes. And isolate number 23, resistant again to the azoles, predominantly in all of them, without an associated genomic resistance. And then, of course, we had one here at caspofungin, which was quite a bit, let's just say, both surprising but not unexpected, which is getting us to think about, could there be other non-detected genomic associations that have not yet been identified that we need to look into? Or B, is there something specific about this bug that would entail us? So we're planning to work a little bit more on the resistance with regards. We're trying to look at actually a bit of the proteomics of it. So I've got an experiment running at the moment. We're trying to identify any specific proteins associated with cell wall proteins in particular. That may be associated with resistance, but my current work up with a colleague of mine who's a chemist, we actually think it's just physical, to be honest, much more than it is genomic, but we are waiting to see. So our conclusions is basically from this one is it's the first time anyone's been able to physically identify and culture. We are so far, there aren't any reports for isolation from wastewater, as in culture. There's molecular identification, but not culture. I think we're the first to report clade 6 from wastewater matrices. We think it's very important for people to establish sentinel surveillance programs to track Candida. And I think from the literature that I've just shared, it is very, very important for people to save their isolates, to try and understand the local epidemiology, because what seems to happen so far is the bug takes a traction of its own within each organization, probably driven by the use or lack of thereof of antifungals or possibly the cleaning agents, or there is something specific to each hospital driving clonal proliferation plus mutation internally, it seems. So I think I'll probably end with this slide here, and I'll open the floor for any discussions. I know that most of you are clinical infectious disease people, and you're probably interested much more on the clinical side of things. There's a few microbiologists that may be interested in the microbiology. I'd be more than happy to take any questions from here on. So thank you.
Thank you, Wael. That was very mind opening, and thank you for all the information. That was very good. I will start with one question. Do you know how stable is the genome of the C. auris under antifungal pressure? Like, how does it adapt? Does it adapt quickly, and how quick is this? I know you mentioned one patient they develop resistance on treatment, but how?
So
what should we expect?
So I think that patient the patient was in Kuwait, reported regionally. So there is evidence to say that expression of resistance does happen individually and within patient, but the problem is we don't know which genes because we're only looking for the common genes that we know. But it is well recorded with Candida auris. You start with a sensitive strain and serially, whilst you start picking it up. We had similar cases in the UK. You start identifying creep up in the MICs. So the probability is yes, there are certain genes that get switched on exposure to the antifungals, and hence the difficulty. So it might be reported initially as sensitive to a particular drug that you decide to use. And with and within that certain patient, you start identifying or witnessing resistance creeping in, but we do not yet know the mechanisms.
Thank you. I'll open the floor if anybody else has. I think Hamid, go ahead.
Thank you, Wael, for the presentation. And as you know, Candida auris is very interesting, and it came to the region a few years ago and caused a lot of havoc here. I'm going to ask you a couple of questions. The first one about the origin of the Candida auris. A lot of people think it's spilled from the environment to hospitals, and that might open the sort of the channel for future spillage of fungi into the hospital environment, and how can that be mitigated? The second question about resistance, I was very intrigued actually when you mentioned before about the resistance of Candida to amphotericin, which is very unusual because Candida is just such an organism you don't expect it to be that resistance. And you talked about the increased concentration; it might eventually prevent resistance. Did you tested your isolate, for example, with higher MICs at all, with higher concentration to see whether this resistant? Because as you can see, Hussam Salah is our mycologist actually, and he reported high level resistant to amphotericin from Qatar. Thank you.
Assalamu alaikum, Dr. Hamid. So with regards to the first question about the origin, whether it started in hospitals or whether it started in the environment, I think it's difficult to say, but the probability is it finds a favorable environment within hospitals. So there may be many reasons for lack of competition. For it's a yeast at the end of the day, and it prefers certain surfaces and certain places. But with lack of competition, because a lot of we tend to forget that bugs evolve together, and usually competition is what puts the balance. In sterile, we know that sterile environments are not good or proliferate one on top of the other. We had the same problem with the Acinetobacter baumannii, and I would imagine that the use of a lot of aldehydes and probably favors those that are able to survive the cleaning, like the Candida auris, like the Acinetobacter baumannii, like the Pseudomonads. So there's certain organisms that end up being associated with hospitals, predominantly or possibly secondary to the way we clean our hospitals, with removing the competition and the ecosystems. So it's sort of a very complex situation whereby if you over clean, you may be supporting those with spores or anything that is able to resist that environment, and hence you end up with more resistant genes, particularly in a hospital. So whether or not it's built from the environment, I think it probably is an environmental, but we have not yet been able to identify any other hosts or natural hosts for Candida auris. As I said, we found it in wastewater. It seems to be able to survive in spore format in different. It's been I've previously found in seawater as well, but not by culture. They did PCR in quite a few different environments. My guess is it's somewhere within urban areas, more likely, and it moves between these urban areas, so apartment buildings to hospitals or hospitals to apartment buildings. I would imagine it's less in suburban areas. Your second question with regards to the amphotericin resistance, as I said, we tested against MIC, so we know what we didn't do resistance with this diffusion or anything. We did MIC, so we know what the MIC was, and the MIC was relatively for the strains that we had was relatively high for these strains. But again, As you are well aware, that resistance is not necessarily always genomic. It may be proteomic, or it may be just physical, or it could be charges, or it could be by virtue of the molecule is too big to go through the cell wall. So I genuinely don't know, and we're trying to identify that.
For example, while this, if you test them by the e-test, for example, this test strip will be impregnated by sort of the special concentration of amphotericin. So this MIC will be reflected on the sort of concentration of the strip, isn't it? Yeah.
Yeah. So we have done MIC. So the MIC for the strain that we had that was resistant was high. Let me just find it if I have it here on this slide. So here, so for the strain that was resistant, the MIC was 4.
Thank you.
I think next Khalid and then Zahir.
طيب شكرا يا وائل على الليكتشر like صراحة it's very enlightful. So a quick question here. I know this might not be something you do, but we have a person here. He's a professor. His name is Mahmoud Gannoum. I don't know if you know him, but he's like big deal into like Candida auris and all that in case. So he basically he advocate for like antimicrobial combination, antimicrobial, antifungal for Candida auris. And I just wanted to know if you have any like experience testing MICs for combination with like mycophenolate and amphotericin B. I just recently had a patient with like Candida auris osteomyelitis and with like epidural infection. It was really bad. Ended up treating amphotericin B and mycophenolate. So my question is there any role for like combination antifungal? Do you know anything about that? And how do you like when you use like dual or like combination antifungal, how do you bypass this like mechanism of resistance? And then just wanted to ask you too, what surveillance system are currently in place to monitor antifungal resistance in Candida auris globally? I mean, I just saw that you are taking care of the surveillance. Anyway, thank you for your talk.
Thank you, Khalid. So I'll start with the last question. There aren't any. We don't even have MICs at the moment. We don't have any breakpoints for Candida auris that are on surveillance. So there's no agreed breakpoints. So that's one of the biggest problems that we have. And for full disclosure, thank God, I'm no longer taking care of patients for the last 4 years. I just enjoy my life playing around in a lab and doing some management. So I haven't been combining antifungals myself, but I did when I was practicing in the UK for Candida auris specifically. There are quite a few reports saying that combination with an azole and amphotericin could be beneficial. Most people would. You see, the problem with these patients usually, they're desperate patients and no one knows what to do. So a lot of us have trialed. I have trialed it myself, and I wouldn't call myself successful. My current inclination, by just looking at the structure of the bug, the cell wall is a hell of a problem in Candida auris. I genuinely believe that it's just a rock. It's just like you're trying to treat a bacillus or any gram-positive at spore level. And when it's just, it's just that. It's as simple as that. If we can grow it a bit, or during, if you start the treatment in the growth phase, not on the stationary phase, you may have better chances of treating it. But my honest opinion is I have no clue. And I don't think many people do, to be honest.
Thank you. Yeah.
Thank you, Wael, for the interesting presentation. First, I'll start with a question about the isolates that you managed to document. I was surprised that the prevalence was very low. Do you think that's artificial, maybe because there's something wrong with the extraction of the isolates from the wastewater? And secondly, do you have specific data as to whether these isolates came from community versus hospital wastewater systems?
So we have the data for what we call the feeder pipe. So I know whether or not there are hospitals in the region, and I can probably guess that there would have been without disclosing. But with regards to the incidents, remember that with wastewater, I'm collecting samples that are representative of a high number population. So you'd have each flush of a toilet or each wash of a sink or each wash of a thing. So this is a for an organism that is not predominant within humans. So the problem is, what is the carried rate of Candida auris? We don't know that. We don't know what is the normal carried rate of Candida auris in Abu Dhabi. If we did, then I'd have an easier way of calculating the incidence here. However, taking it back into, when you think that out of every 23,000 samples of wastewater, and each sample is representative of approximately 5,000 to 6,000 people, you can probably backtrack what the relative incidence is within the population that we have. And the other thing is, getting it from wastewater in itself was a feat. It's not easy at all, because you have to pre-concentrate your sample, and there aren't any standard methods for us to say that this is how we get or how we don't get. And there's also a lot of other inhibitors within wastewater. So remember that you don't know in the sample that you have if someone has flushed Clorox or hypochlorite or oil, or anything else that would cause disruption or inhibition of this isolate. So there are many variables in play, but we can probably, using mathematical modeling, which we have already done actually, estimate. It's predominantly based on work that was done on COVID for wastewater surveillance, that you can estimate the population prevalence of an organism that we have done already. So I think relatively it's not low. I don't think it's low, Zahir.
Mm-hmm. Yeah, I think that's my impression as well. And I think it will be useful, as we previously discussed, to triangulate this data with hospital data to try and have a better understanding of the molecular identity of these bugs.
We intend to, but as you understand, sometimes there are certain limiting factors in these types of research in the region.
So I've got other comments just in general in response to some of the earlier discussion. So I think in our clinical practice, we see a fair amount of bloodstream infections with Candida auris. They seem to be universally susceptible to echinocandins. And by that, we haven't experienced clinical failures by using echinocandins as first line. Typically, the lab will report resistance to amphotericin B, as you mentioned, and fluconazole, with variable susceptibility to voriconazole. Just in response to the point that Khalid raised about combination therapy for Candida auris infection, I only remember maybe one or two patients in which we thought about adding cytosine to mycophagians based on some recommendations from the US based on limited data. But apart from one or two instances, I can't really recall some that we struggled to treat with antifungals. Even with osteomyelitis, I recently treated a patient with osteomyelitis with just mycophagian. He was treated as an outpatient via OPAT.
So yeah, I think, as I said, out of interest, Zahir, how much do you use caspofungin? Out of interest, because you're the only one here from the UAE.
So,
is it a commonly used antifungal in the hospitals? Which of the echinocandins is the most commonly used here? Out of interest, because I'm just looking at the strains here.
So mycophagian and anidulafungin are the workhorse echinocandins. Caspofungin, I've got issues. I think cost is an issue, and also, as you know, most labs extrapolate caspofungin susceptibility when it comes to Candida of any species, and therefore it's not really our first line. We use either mycophagian or anidulafungin.
Good. So thank you. And do you know how they test for sensitivity in the labs, that in your hospital lab? Do you actually, or do you just get reports saying?
Yeah. So obviously the biotech will throw something, but they will do microbial dilution to establish the sensitivity.
Okay, thank you. Super. That's good to know.
Khalid, do you have another question?
Yeah, I just wanted to comment على النقطة بتاعت زاهر طبعا. Thank you for the comment, but we had the patient we were treating there was an issue with I'm pretty sure you know that, but basically the penetration of the antifungals to the bone. There was a concern about like a kind of candida is not penetrating into the bone and all that. So that was some kind of issue. That's what triggered the discussion about the combination chemotherapy. I mean, luckily the patient cured. So I mean, it seems like there's way out, but it's just like using which medications and while points on the presentation, the CLSI breakpoints are not um, being correlated to clinical outcomes. So it's just like it's been like really difficult when we see Candida auris most of the time, because it's just like, there's always some issues, whether like, polypharmacy, drug interaction, and the site of infection too, especially the bone, and the kind of Candida's data is not very promising when it comes to bone penetration. All right, thank you.
Dr. Omar?
Thank you, Wael. This is fabulous. I think it's great work and nice to see that. A comment and a question. Comment. I totally agree with your analysis about Candida and dynamics of resistance and creeping MICs, but I think it's probably twofold. I think the capsule or the cell wall or whatever plays a role in halting it initially, but I think later on, when it swims in floods of echinocandins for quite some time, and the genomics kicks in, and that's when they start to really become trouble in treating it. And we do see these patients quite a lot, where the weeks on end are pandemic, and they're not seemingly responding, but then the week after, the month after, they become quite resistant with high MICs, whatever that means, and then you start with combinations. So that's my comment, but my question is really not clinical. My question is, how did you select your sites, and what did you have an SOP for selecting your sites, and what was your rationale behind the different sites? And is it something that you would be prepared to share, please? Thank you.
Okay, so with regards to your first comment, I think you're absolutely right. We don't know much about yeasts in general, not only Candida auris, or a lot about the fungal infections in humans. And we also tend to forget, unlike bacteriology, there's different status in different times for these yeasts. So if you think about the Aspergillus, or if you think about, and within the environment, and they behave very differently. So on a plate, a yeast on a plate is not necessarily behaving exactly the same that it would in a bone or on a blood culture or on a urine sample. So and we tend to forget the biology, basically, is what I'm trying to say. And we're trying to use a hammer to treat all of these things. I think we need a little bit more work into understanding the dynamics of how yeasts behave in biological models, whether these are cell lines or something like that. With regards to the sites, we are currently running one of the world's largest wastewater surveillance programs. We are monitoring the sewage water in all of Abu Dhabi daily, and it's distributed. We distributed it along all of the Emirate of Abu Dhabi samples as part of the COVID project at the time. So we have a significant surveillance of wastewater for infectious diseases at the moment. I think if it's not the largest project on the planet, it probably is one of the largest 2 or 3. So we have autosamplers throughout the city at the moment as part of the COVID legacy.
Thanks, Wael. That's fabulous.
Yeah.
Osama Ahmed, can go ahead.
Thank you very much for the presentation. Amazing as usual, طبعا. While I would like you to comment on the discrepancy between the MIC for the different echinocandins. There is like discrepancy between the MICs for caspofungin and the rest of the echinocandins. From what I remember, in the Gulf, they used to use caspofungin more than the others, but I'm not up to date with that.
And that's why I asked Zahir, actually. I think you're right. I think historically, that's the exact same reason why I asked Zahir, what are they using mostly? I have a feeling it may be a historical evolution. So people moved from caspofungin following the creeping of resistance. So it may have been one that they used much more than they have, and now they've moved to micafungin and idilofungin, and hence in the isolates that I have much more caspofungin resistant. But even caspofungin as a molecule, I think in itself is larger than both idilofungin and micafungin. And in itself, it may not be the best antifungal for Candida.
Thank you very much, Wael. That's really helpful.
Ahmed Abu Bakr.
Thank you, Wael. Really, I enjoyed the presentation. Really amazing work what you've been doing. And during your presentation, you mentioned you advise people to keep the culture positive from the blood. Just what is your rationale behind that for keeping the isolate? And the second question is we see quite a lot here, but and we see quite a lot of the PCR positive on the floor when they isolate them. Anything we need to do about those patients that they were positive? They have PCR positive.
Out of interest, where are you based at the moment where they're doing PCR?
Sorry, in Michigan.
In Michigan. And they're using PCR for which PCR? Are they using
like swab PCR from the I believe it is from the groin area.
They're using screening, يعني Candida carriers.
Yes.
For Candida auris, they're using screening with PCR.
Correct.
Interesting. So I think part of the problem is with PCR for Candida auris, I think I don't think it's a good test at all, and I think they're probably picking up the wrong bugs, to be honest. Even after we culture it, we find difficulty in extracting DNA. Even after culture, it takes us sometimes 3, 4, 5 different cycles of just heating acids, knocking it out physically to just get a little bit of DNA. So personally, I would probably ask your team about if they have run sensitivity and specificity and validation studies on these PCRs, or is it something that they're using from generic? Because I genuinely doubt that it's
useful.
It is. I genuinely doubt. The problem is they're probably also using short primers, and they may be picking another Candida rather than Candida auris. As I said, it's getting the DNA of Candida auris is a pain in the backside.
I see.
Yeah, just getting the DNA, not the the extraction is not easy. It's one of the most difficult I had to deal with, to be honest.
I see. Very interesting. I guess I didn't know. I mean, I'm on the clinical side, so the infection control are separate departments. So I didn't know how did they come with this idea of getting the PCR then.
I think sometimes I used to do a lot of infection control, and a lot of people do a lot of reactive tests in many hospitals that, without understanding I doubt. I will have to. I'll have to look at which one they're using specifically, but it is worth questioning them specifically about which test, because you may be mismanaging your patients if the test is incorrect, to be honest.
Yeah, I mean, and cost also, those patients on isolation in a separate room.
Absolutely. Unless you have an outbreak in your hospital that is documented with yeast and with Candida auris, I would very gently ask that the microbiology lab to learn from them. I mean, maybe they've got their own assay for extraction that we're not aware of.
And why you want to keep the isolate a while? Why you want to keep the positive culture and the blood isolate?
I think it's really important for you to create, for each hospital seems to have, or each organization, each hospital that I've been looking into, seems to evolve its own clade, its own cluster of Candida auris. So it seems to be a bug that that evolves within an ecosystem. So you may find hospital A very different to hospital B, and hence a global approach may not be the right approach for us. And that's why you would want to keep a library for some time to understand the evolution within your own organization. As I said, I've just shown in Saudi Arabia, in Kuwait, and Qatar, they are all. We had a look at all of them, so they're all clade 1s. But the clade 1s within each hospital, within each country, between all of us, are all very different in terms of their behavior, in terms of the genes that they have, in terms of the resistance that they have, in terms of the mutations that they have, and even the lineages within each hospital is different. So there must be some other reintroductions, and then you end up with a clonal proliferation, or sometimes you have more than one clone within the same hospital that is also evolving separately from the others.
Yeah, and that also might have to do something with their infection control prevention method they are using for disinfection and
correct. So there's many variables, which may differ from what you clean your hospital with, for example, may be different from hospital A to hospital B, and hence you will have a different sort of evolution.
Thank you, Wael.
Mustafa, you can go ahead, and then we can ask Hamad and Khalid after you. Go ahead, Mustafa.
I'm just jumping in because of the infection control and the sensitivity, specificity, and validation of the PCRs. So I've been looking at this recently. As you probably know, candidiasis is a nightmare in big hospitals in the Gulf generally, but in Saudi, I don't know the exact situation, but it is a nightmare here, and we're having issues with bed flow and so forth. So the PCR, I think the Sorin have a solution, and Bosch as well. And I just wanted to ask your opinion, Wael. So yes, I know the reliability of a test, particularly if it gives you like a positive ORIS, would be questionable, and it could very much be picking up some other Candida species. But would you rely on a negative, particularly that you said you are facing problems extracting the DNA? And as you know, in infection control, if I get a negative, that might be a good answer for me. And I will deal with the positives later.
Yeah. So Mustafa, I know you worked in Bristol with a very eminent team that works with candidates where we all go and get our training done for the FRC path exam. So I doubt they're doing that at Bristol. I genuinely doubt that they would be using PCR at Bristol for screening for Candida auris. And if I don't think it's a cost issue either.
Yeah, no, they just didn't believe in it.
Yes, and I think the reason is the negative predictive value is actually quite low. Yeah, so if the negative predictive value was high, I would have said yes, go with it. But I promise you, it is one of the hardest things to get DNA out of. A Cryptococcus is not as difficult to get DNA out of than Candida auris. We really struggled, and we followed all of the SOPs available. And I was genuinely surprised at how difficult it was for us to get DNA out of this bug. And that's why I think maybe we can use, maybe it may be easier to develop some other tests based on proteomics than it is on PCR.
Thanks, Wael. That's really helpful.
Thank you.
I think we can, there is maybe follow-up questions from Khalid and Hamad. Is that right? Or your hand raised?
Yeah, well, just to clarify, the clade that we have in US here is clade 4, the Colombia one. I mean, I just kind of trying to remember. And then my next, just to, one more point is there like any particular region in the world that has like the highest concentration of like pan-resistant Candida auris? What's the worst clade that you don't want to like really see in your patient?
So at the moment, clade 6 seems to be the most interesting one in terms of profile at the moment. Momentarily, we don't know yet. The US, I'd expect you're going to have all of them. You're going to have likely clade 1, but you're more likely to have clade 4 because of proximity, and where we don't get South Americans traveling to and from Europe for hospitals, but you probably get them to the US. So clade 1 is probably the most one distributed, is actually clade 1 around the globe. With regards to pan resistance, it seems to be pockets. So hospital A in England would have it, hospital B wouldn't. Hospital in Scotland, they may have one, in Wales, they might not. Saudi Arabia is going to be very interesting, in my opinion, and the Middle East in general, because I can see a lot of people marketing antifungals, and the use of antifungals is quite high, it seems, from what I'm used to. At least Zahir and people practicing at the moment may confirm or reject that, but I have a feeling that the utilization of antifungals here may be a little bit more than I was used to in England, and the marketing of it. And of course, India, as always, would be an interesting place. But again, we don't have enough data.
Thank you so much. Thank you.
I was intrigued by the fact that with your data suggests prominence of phenotype or clade 6. But whereas in so many ways, our practice kind of reflects what's going on in the Indian subcontinent. So I think that's an interesting finding, I think, for me.
Yeah, so what we have in the UAE predominantly is clade 1. So none of the isolates are South Asian clade 1. But the fact that we found one clade 6 is probably telling me that there might be a little bit more of clade 6 circulating in hospitals, because I got 1 out of 9. So if you reflect that into the total number of patients, so maybe a 10th at the moment. But the problem is you don't know which one is going to proliferate in the next couple of months or weeks.
Yeah.
So, but we have it.
On the discussion around screening for Candida auris, I mean, at the moment we're using culture methods, but these are, as you know, quite insensitive. So we do tend to miss quite a few, and also it's not fast. And I remember having a discussion in our team about molecular testing based on some cost effectiveness data, based on the utilization of PCR testing or screening for Candida auris. I think it came from the US, if I remember correctly. I'll try and dig out that paper. I think it was an in-house assay, so obviously we don't have much information about what goes in there.
The assay is not
the commercial
assay. The assay is not the problem. The problem is not the primers at all. The primer I'm not worried about. It's the ability.
The extraction, as you said, I think mainly.
Yeah, the extraction is the problem.
Yeah.
That is the big problem. And most people would be using magnetic beads for high throughput. Most people, they would not even be using the centrifugations with the QIAGEN spin or they're not going to be doing lysis with heat, or we had to do physical lysis to get this thing out.
Yeah. But I think, the point Ahmed was making earlier, I think this has got direct cost implications when you isolate patients and you create pressure on beds and all that kind of thing. So the workflow within the hospital will be adversely affected when we just rely on slow methods like culture, for instance. So I think there's a need for better molecular identification. And as you said, maybe we should work more hard on getting the right extraction kits for this kind of beast.
Yeah, we are trying to look at the moment. One of my postdocs is working on. We're trying to identify if there are any organic compounds that we can use to identify it. So if we can, we think all of these bugs would have a protein of one form or other that could probably be identified quicker. So we have someone working on that at the moment.
Hamad, do you have follow-up question or your hand is raised?
I want to have a few comments actually, just to give you our experience and things. A few things actually. We have the Candida auris in 2019 before the COVID, and then it stayed. And when we looked at other experience in people in the region, including Saudi Arabia, all the experiences for all other hospitals in the region and elsewhere, when you have Candida auris in your hospital, it will stay. It will be very difficult for you to get it rid of, and most people will just control it. So this is the second thing. The second thing about the antifungal, which Weil talked, about echinocandins. In the region, from my sort of experience in this area, casbofungin is almost 70-80% have market share of the echinocandins in the Gulf region. Although in Qatar we have the other way around, and idulafungin more than caspofungin. Micafungin in Abu Dhabi is a recent thing because it's just on cost issue. So the resistance from caspofungins, I suspect, because of the widely use of it. And then the infection control, which is Mustafa's trying to explore, and others as well as while. When we had the Candida auris here in Qatar, we started with the culture method as a standard sort of method. But the turnaround time, this patient moving between, Candida auris unit from ICU outside, it might take, 5 to 10 days to lift the isolation from patients. So people thought it was, impractical to do that. So we introduced the PCR with all the limitations. A lot of discussion in the infection control, went through this, whether the PCR is sensitive enough, but you have to be eventually practical. It's a nightmare, as Mustafa mentioned, and how to go through it, the detection method. And very important thing, I think, in Hussam Salah's study, 90% of Candida, in our setting is colonization, and the invasive disease maybe 5 to 10%. So the majority of infection is not easy. The majority we are dealing with colonization. So you have to put sort of method or strategy how to control it and how to, to manage it. It's a very difficult situation. Thank you.
So if I may just make a small comment. I think part of the problem is the egg or the chicken. The assumption that the patient is colonized and isolating the patient may not be the right approach, because the probability and the possibility of the room being colonized, especially that you guys probably have a lot of single patient rooms, not wards, and that it's just lurking in the room, whereby you're picking up the DNA, which is transient, is also a high possibility here. That's why.
It's quite possible, yes.
So that's part of the problem. Is if it's in the environment. Once it's in the environment, as I said, getting stuff from wastewater, it's a very hostile environment, and if a bug grows in wastewater, I'm interested in it because it's I'm looking at a lot of the evolution and then the variants that are able to survive this hostile environment. So all I'm saying is, once we had this experience in England with Acinetobacter baumannii, and once you're colonized or the building is colonized, I think you may as well just have a different way of looking at things. The question is, how do you get it out of the environment rather than out of that individual patient? And you end up concentrating all of the patients with Candida auris in the same side room, so you probably end up, in any case, causing sort of a drift within your organization because of what you're doing. So it's sort of a very difficult situation from an infection control point of view. Sorry.
Go ahead, Rahim.
I think we haven't yet, maybe thought of, while mentioning the issue about the environment, but also for the patients, we haven't really got any effective decolonization regimens for these patients. And also, maybe we don't go far enough to decontaminate the environment. And by that, maybe the ventilation systems, the equipment in the room, and promoting hand hygiene, all that kind of thing. So I think there's a lot of work to be done to optimize the control of this nasty bug. Thank you, Wael, again.
Thank you, Zan.
Thank you, Wael, so much for the insightful and timely presentation on the genomics of Candida auris. Your presentation was both fascinating and deeply relevant to the challenges now we face in the clinical and public health setting. We appreciate the clarity of your presentation, presenting such a complex topic and make it very understandable for us. And thank you again for sharing your expertise, and we hope to see you again in another talks.